Hello and welcome to this very special discussion courtesy of the European Institute of Health and Sustainable Development. This topic is a Europe-wide discussion about Europe's health sector, and the subject matter is time to strengthen the EU's public health policy powers, a manifesto for a European health union. Hello and welcome to all of you. My name is Joe Lynham. I present a programme on the BBC World Service called The Newsroom. Before that, I was a business correspondent for very many years, and I was a correspondent in Brussels, in which time I did quite a few stories about business, but also met quite a few commissioners. And we have two former commissioners, no less, joining us on our discussion today. I hope all of you are well. I know this has been a very testing time for all of you. Millions of Europeans have been affected by the coronavirus, and unfortunately, tens of thousands of Europeans have died as a direct result of it. What the crisis has highlighted, though, is a huge gap between the healthcare service in each individual member states and the need to coordinate health services in the event of the next big pandemic, which I'm sure will be coming along at some stage, hopefully not in the near future. We're going to discuss some of those challenges today with our manifesto. For too long in Europe, the accusation has been we have focused on health above wealth. We have prioritized making money above the mental and physical well-being of our citizens. The COVID-19 crisis has reminded us that when we're not well, money doesn't matter. Human beings matter. There's no point in earning money if you're too sick to spend it. So people like Vytenis Andriukaitis and Ilona Kirkbush and others will be talking about a European healthcare solution, a Europe-wide solution. Today's session is incredibly prescient. Only a week ago, the President of the European Commission, Ursula von der Leyen, gave her State of the European Union address in which she called for a European health union. She said, and I quote, "We need to strengthen our crisis preparedness and management of cross-border health threats." We'll be speaking to some of Europe's key people in this area over the next hour and a half or so who want that dream to be realised, and have published a manifesto which Vytenis will be telling you more about in due course. We will be hearing his manifesto, but we'll also hear from Professor Martin McKee from the London School of Hygiene and Tropical Medicine. Martin will ask the question, how can we build back better? And what lessons can we learn from the coronavirus crisis? We'll then hear, hopefully, from Professor Ilona Kirkbush from the University of Geneva. A big hello, Ilona. And she is the co-chair of today's webcast, and she will talk about the EU's role and responsibilities in global healthcare. After that, we'll hear from Josep Figueras, who is the head of the European Observatory on Health Systems and Policy. Josep, hello in Spain. And Josep will focus on the cost effectiveness rationale, followed by Assistant Professor Aniek de Ruiter, who is an expert on European law at the University of Amsterdam. Goedemiddag, Aniek. And she will look at the legal implications of a European health union. After we've heard from the experts, we're going to go to get the perspective from the key stakeholders, the people that really matter in this industry and who would be affected by any European health union. We're going to start off with the former Commissioner Violeta Bulc, who was the Transport Commissioner until the end of last year, no less, and was also Deputy Prime Minister in her native Slovenia. Well done, Violeta, on winning the Tour de France. And then we're going to go to Dr. Markus Schneider, who is from Basis in Augsburg. Guten Nachmittag, guten Tag, Markus. We look forward to hearing from you. And then hopefully we'll also get Dr. Juozas Olekas, who is a Lithuanian member of the European Parliament. He's behind the screens, if you know what I mean. Once Vytenis has spoken, he'll take the seat and he'll join us. And he's a surgeon, no less, as well. So he's got a fair bit to say on this. You have already been sent their biographies. I'm not going to spend too much time. These people are too educated. They've got too much stuff on their CV. I'm not going to waste any more time talking about it. I wish I was half as qualified as these people. We will be opening it up to you guys, to you out there. please contribute something and throw in your thoughts and your questions, because this is a very distinguished panel we have here. If you have a look on the bottom right of your panel on your Microsoft Teams, you'll see two little kind of exclamation bubbles. If you touch it, it'll show Q&A, questions and answers. That's where you post your questions or your comments. And if we've time, I will be able to post those questions to our very distinguished panel as well. There will also be a simultaneous translation facility on this. I think it's available in 6 languages. To be honest with you, I don't know how to get it, but in the course of today's discussion, I will tell you how to get it. I think you click the 3 dots and look for subtitles on the translation. If you wish to get one of the 6 languages translated in subtitle format, please go to there. Everything will be on the record, so please do not defame or be rude to anyone. That would be great. Without further ado, I'd like to hand over to Dr. Vytenis Andriukaitis, the former European Commissioner for Health, for his presentation of the manifesto. Vytenis.
Citizens, friends, like-minded colleagues, today is 24th of September. It has been 9 months since the world has been hit by a major crisis. This crisis bears the name of COVID-19. It affects millions of people around the world. It took almost 1 million lives away. These are not just numbers. These are people we love, our family members, friends, colleagues. I want therefore to speak on behalf of those who left us, on who lost their loved ones because of this terrible pandemic, but also due to the lack of coordinated actions from the EU side and also globally. Better health is one of the most important issues for the Europeans. And moreover, during decades of continuous growth, health developed as one of the most significant sectors of the modern economy. But we're witnessing, unfortunately, that health has been almost ignored by the mainstream European policy. The COVID-19 pandemic revealed limits of preparedness to mitigate negative impact of health emergencies on economic growth, employment, fiscal balances, international trade, free movement of people. The EU is now at crossroads to respond to this health, economic, and social crisis. It can choose to continue doing business as usual with some improvement of today's tools, or it can take on more responsibility by strengthening the treaties in the field of health at the EU level. How can we, drawing lessons from the current crisis, create a resilient EU that can move forward with confidence and vitality, keeping in mind people's health, well-being, and quality of life? In all European nations, understanding or perception of life and health as social, mental, and physical well-being is one of the most important pillars of welfare. Value of health is a cultural backbone of our civilization. It is not without a reason that we wish each other good health and longevity when we meet as individuals, families, and communities. These preferences of European citizens spill over to a broader dimension and are clearly reflected by asking governments to provide for more budgetary and human resources to this end. Unfortunately, until recently, European policy was somehow disregarding health-related values of its residents. Most of health-related matters are considered by the EU exclusively as business of member states or markets. Until COVID-19, health remained a minor topic in the European treaties, the European semester, or the EU budget. The, I quote, EU does not take action, prevails against, I quote, unless it is more effective than action taken at national, regional, or local level. This is how, in usually everyday practice, subsidiarity principle and role of the EU in health is interpreted. But Eurobarometer indicates clear preference of European citizens to do more for health. Regrettably, the initial Commission proposal to increase the health budget seems not to be retained, The proposed EU for Health program has been cut by 75%, and this is a clear indication of a gap between actions of Europeans, those who take final decisions, and expectations of European citizens. This gap between expectations of Europeans and political reality has to be closed. Now it's crystal clear to many Europeans, including patients, healthcare professionals, progressive politicians, that that health is a big issue, and we have to seize this window of opportunity to ensure strong public action to transform the cooperation at the EU level. A part of being the EU as a bloc that cares about free movement of goods, people, services, and capital. The bloc that considers monetary, banking, or fiscal union. The European Union should evolve as a union where lives and health of all residents matters. The European Health Union. It is time to act for better health in Europe. The health community is glad to hear that in her State of the Union speech, the Commission President acknowledged that the European Health Union is now on the priority list. The document is in making that we are going to discuss today, Manifesto for a European Health Union, aims to kickstart broad public debates on what the European Health Union is about and to urge in the run-up to the European Councils and the Conference on the Future of Europe, the leaders of European nations and the European Union to commit to give some real muscles to the EU's health policy powers. I would like to highlight some suggested features of the future European Health Union. First, the role of health policy in the European treaties will be reconsidered and strengthened. The objectives to keep in mind are more proactive and preventive health, more solidarity in public health activities in Europe, more cooperation to build resilient healthcare and care systems. No longer will laws with important consequences for health be adopted as part of the EU's market-building objectives. Second, there will be sufficient capacity to safeguard EU solidarity, as when there are shortages of medical supplies simultaneously facing many member states. The EU will be empowered in some areas to ensure centralized distributions of emergency medicines and supplies based on medical need. Third, cross-border healthcare directive is not enough. We need the EU to share responsibility in care and cure in the areas of rare cancers and rare diseases while preserving subsidiarity as a core principle. We need the European Health Insurance Fund to cover rare diseases and to assure that the pledge "no one is left behind" is reality in Europe. None of the European countries alone is capable to assure universal health coverage for all up to 30 million European Union patients suffering from rare diseases. The European Health Union can do it. On May 9 of 2020, Europe commemorated 70th anniversary of Robert Schuman Declaration that paved way for the EU. The history of the Union shows that none of transformations comes fast or easy. But let's be bold. Let's be inspired by paraphrased call of Robert Schuman. People health, I quote, cannot be safeguarded without the making of creative efforts proportionate to the dangers which threaten it. You want my reply to the question that the EU is constantly asking itself, namely, how to bring the EU closer to citizens? The answer is European Health Union. It can do this. Health is a political choice. Don't miss a generational opportunity to place health at the center of our European Union. Let's be brave. Let's be thoughtful. Let's seize this opportunity together. Let's work together to rebuild trust between member states, to strengthen citizens' confidence in our capacity to manage health crisis and to move onward. Health is trending, colleagues. The draft manifesto is a result of the collective actions. All speakers of the panel are co-authors of the document. I am looking forward to hearing their views. Thank you, colleagues. Let's talk. Unmute.
Joe, you need to unmute.
Joe, you need to unmute. We didn't hear you.
Oh, my fault, actually. Apologies to all of you. I spoke without clicking. This is the danger, of course, when you're having these discussions. You forget to unmute yourself. Thank you very much, Dr. Andrew Kaitis, and I'm looking forward to discussing some of those pretty interesting ideas, including cross-border long-term care. I'm sure that'll be politically very sensitive. I'm now going to turn to Professor Martin McKee from the London School of Hygiene and Tropical Medicine. Now, Martin, you're going to ask the question. I don't know whether you're going to answer it or not. Whether we can build back better and what lessons we can learn from the coronavirus.
Well, thank you very much. Thank you very much indeed. And as Vitenis has said, the COVID pandemic has already claimed almost 1 million lives worldwide. And of course, in the coming months, that number will increase further. But we know that not everyone has been impacted to the same extent. The pandemic has brought into sharp relief the inequalities and injustices in our societies. One of the most important risk factors for infection and death from COVID is being poor. But the pandemic has also created hope. People have found new ways of working. Millions who endured the daily commute to work in large cities have realized there is an alternative. And just like our predecessors in the 19th century, we are realizing that the conditions of the most marginalized in our societies, such as those working in poorly regulated workplaces where the virus is being transmitted, are, something has happened to the screen here.
If you want, Martin, we can move on to Ilona and come back to you.
No, it's okay. We're realizing that those working in poorly regulated workplaces are a threat not just to themselves, but also to us. Organizations representing over 40 million health workers called upon the G20 leaders to recognize recovery plans as catalysts for change, building a better world that will allow people and the planet to, and I quote, come back stronger, healthier and more resilient. The Lancet Planetary Health sees this as a time to harness the window of opportunity that the COVID-19 response is opening. And it's not just the health community. Current and former central bankers believe that the crisis offers us a once-in-a-lifetime opportunity to rebuild our economy in order to withstand the next shock coming our way, climate breakdown, calling for a green recovery agenda centred on the aim to build back better. Well, the idea that a crisis provides an opportunity is not new. Natural and man-made disasters have often been catalysts for change. Rebecca Solnit describes how, armed with compassion, people mobilize at times of crisis to help strangers to rebuild communities. But there are others who also try not to let a crisis go to waste. Naomi Klein, in her book Shock Doctrine, describes the activities of those she calls disaster capitalists who exploit the weaknesses of those trying to rebuild their lives. Even though the pandemic is less than a year old, many have already profited. For example, through abuses of procurement that in some countries look very much like corruption on a grand scale. And as in the financial crisis, business leaders that demand that governments leave them alone in the good times are only too happy to accept corporate welfare paid from the pockets of the poor. At times like this, it's essential that we learn from history. Rudolf Virchow, the eminent Berlin pathologist, was asked to investigate an epidemic of typhus in Silesia in the 19th century. He recognized that the solution lay in the political realm, with patterns of disease shaped by the distribution of power within society. So as we seek to build back better, we in public health must strive to make the invisible visible, whether it be invisible people, invisible issues, or invisible evidence. We must give a voice to the voiceless, And we must challenge existing power structures, especially where that power is hidden from view. And yes, this includes the power of those who control the algorithms that make decisions about us, and the power of those who manipulate social media to influence our thinking. We need strong systems of governance that are transparent, accountable and participative. Now, I'm a public health doctor, but I haven't spoken about the specific health threats we face. I don't think we need to. This year, we've seen what happens when we take nature for granted. We share this planet with many other species. We can exploit them, as in the sale of wild animals in the wet market in Wuhan or our deforestation of the Amazon. Yet, as we've seen, any short-term gain for some people brings long-term pain for us all. Everywhere.
Oh dear. Martin. Have we lost you, Martin? Well, he's frozen for a little bit. So I'm gonna continue. Martin, we lost your last sentence there. You kind of froze for a bit. Can you hear us now, Martin?
Yeah, sure. Where did you miss me?
Just the last 20 minutes. If you could repeat. Oh, I'm kidding. Don't worry. Just the last sentence, Martin, please.
Everywhere we look, at the melting ice sheets of Antarctica, the forest fires in California, the plagues of locusts in Africa, we see that our current way of doing things is unsustainable. These events may seem far away from Europe, but their consequences are not, as we've seen in the migration crisis. COVID has been a wake-up call for us all. We have no alternative to build back better. Thank you very much.
Thank you, Martin. And I'm sure you've cleared it with Joe Biden, to use his phrase of build back better. He's using that one a lot. Thank you, Martin, for that. And we'll come back to you to discuss some of those very important issues. I'm going to turn to Professor Ilona Kickbush now from the University of Geneva, and the co-chair of today's webcast, along with Vitanus. And she'll talk about the EU's role and responsibilities in global health. Professor Kickbush. Now you need to unmute. There we go. You need to unmute. Ilona. Now, I was guilty the last time, but if you could click.
Yes,
there you go.
after calling on you. So thank you very much, Joe, and hello to everyone out there. I do have a small correction, though. I'm not at the University of Geneva. I'm at the Graduate Institute of International and Development Studies. And I think that in itself is an important message about the relevance of international relations and development thinking in global health and in health in general. I'm incredibly pleased that in the context of thinking about a European health union, the global dimension is included, because in my view, one cannot think of a European health union without that global dimension. Sadly, before COVID-19, the global dimension that had come into the European Union through the Council conclusions in 2010 and a global health strategy that was actually written then got lost. It's disappeared. But we see right now that through COVID-19, we have a new opportunity to really highlight the global dimension, the global responsibilities, the global contributions such a European health union must take forward. And we have seen in practice already since early this year how the European Union has become a much more proactive participant in global health. And I will mention one or two of those issues. I think I also need to mention, though, that even before COVID-19, a group of upcoming presidencies actually came together to say we need to strengthen global health again within the European Union. And there is an active working group of right now about 6-7 presidencies, starting looking back to the Finnish presidency, at present run by the German presidency, but already including the 3-4 upcoming presidencies, to see how to take this global dimension forward. And that, of course, I think is already a good point, to know that both the Commission is active, that a group of presidencies wants to take this agenda forward, and we hope also that the European Parliament will become a very important actor here as well. I think an interesting example for how one could approach within the context of a European Health Union, the global health dimension, is to approach it in a similar way that the agreement on the development approach between the the Union, the Parliament, and the presidencies has been taken forward, and that could be a model. If we look at how the European Union should act globally, I think it's three dimensions. It's a political dimension, it's a legal dimension, and obviously it's a technical dimension. Politically, and we've already seen that being played out, the commitment of the European Union to multilateralism in general and to multilateralism in health is absolutely critical, and a very, very strong voice at a point in time when, for example, the United States is moving away from multilateralism. That multilateralism is important in terms of the support to the World Health Organization. And it's important to see that at this year's World Health Assembly in May, it was the European Union that took forward the action of consensus between over 170 member states of the WHO to support WHO and to chart the way forward in COVID-19. It's also important, though, that the European Union become a strong voice for common goods, or global public goods, as it is often called, in relation to global health. And it will be absolutely critical to see how the European Union will, over the next months, act in relation to vaccines. It has joined the COVAX initiative, but one is waiting for additional activities and additional commitments, also financial commitments, to ensure that we do not see major global inequalities in relation to vaccine access. And I believe anything the European Union will do in relation to global health, its credibility will hinge on how it now relates to vaccines. In relation to legal issues, we know that much of the EU status and soft power is based on the rule of law, and therefore it is absolutely critical that the EU play an important role in relation to global agreements or global instruments that are required. At this point in time, a priority is, on the one hand, the revision of the international health regulations, where we truly need a new understanding of sovereignty and of sharing responsibility and giving WHO more power, but also in the area that Martin McKee has already mentioned, that the EU could take a lead in ensuring health rights and citizens' rights in the digital space. And of course, anything in the broader digital space will have an impact on the approach to health data, on the privacy of health data, and various health platforms. The European Union speaks about health sovereignty of the Union and digital sovereignty of the Union, and that is something that needs to be taken forward. Obviously, in the technical area, there's an enormous amount of points where the European Union can set priorities. I won't go into that right now, but I think what it indicates is that because there are so many areas in which the Union must act, very closely linked to health, but also we've heard agricultural policy, social protection, trade, supply chains. That is again a strong reason why we should have a European health strategy that actually sets such priorities, and that possibly can be the basis of a new set of Council conclusions on global health that we would need. The last point I want to raise is the relationship that the European Union must build in even stronger ways with the World Health Organization. It is often forgotten also now in the budget discussions of WHO that the EU is the WHO's largest financial contributor. And the EU must relate its financial role also to its policy and political role. But what we do not want in the context of WHO is for the EU in a way to come in and say, okay, now we're going to call the shots and replace the United States. No. What we need is a new kind of partnership model in global health, where countries work together in a new way. We have indications of that, of the European Union working with the African Union, for example. And I think if the European Union becomes a leader in the sense of a leader for partnership in global health, and not we are the leaders, we from the global north, I think there can be a tremendous development in global health, a greater sharing of responsibility, and a greater sharing of moving forward together. So I would leave those points here for discussion and hope we will have an opportunity to discuss, particularly the political and the financial role that the European Union plays, and to see that as a defender of rule of law and human rights, it takes that kind of thinking to the global health arena. Thank you.
Thank you, Ilona, for your contribution. And I just want, before we come to Josep Figueras, I'm going to remind him to unmute his microphone now before he forgets, and maybe just stand in the center of the screen, just slightly over to the right as we're looking at you, Josep. Yes, that's much better. Don't forget to unmute your microphone now. We don't want any more embarrassing pauses. Just to remind you that there are questions that you can pose. If you tap your screen, you'll see on the right-hand side the two dialog boxes. Click that. There is already a question there. I'm going to be putting that to the panel in due course. But first of all, I want to go to Josep Figueras, who is the head of the European Observatory on Health Systems and Policy. And Josep will focus on the cost effectiveness rationale. Josep, nice and center.
Thank you, Joe. Centered, connected, couldn't start better. A real pleasure to be here today. I think I got the difficult job here because my point here is going to be, can we defend a European Health Union on cost effectiveness terms? And in doing so, perhaps you fall a bit onto the cynicism of the economics. But let me try that. I suppose there are two themes that are underlying this debate that are important to highlight. One is the solidarity. My point here, and where I may sound cynic, is that in many instances, what are solidarity arguments to which I subscribe? The European Union has explicit role of values, is a political element, has a political grounds, needless to say. The human rights, the justice are very much part of what the European Health Union is about. But my argument is going beyond that, is saying, actually, in many instances, solidarity pays off in terms of efficiency, in terms of sustainability. Take the universal health coverage. We should not leave anyone behind because it is our value. But have you realized how expensive it is in the US, for instance, to leave people behind? The cost for societies to leave someone behind. The way that it affects the healthcare cost, the social cost, the way that affects the productivity, the way it affects the societal well-being and cohesion, which at the same time has an impact on the economy. So we should be aware of those themes as well, although I subscribe entirely about on the European, of the EU, of values, of solidarity, human dignity, and so on. So that's my first theme today. The second theme that underlines my comments on my rationale for the European Health Union based on cost-effectiveness analysis is that I would argue that subsidiarity, being a principle that we all subscribe, is fundamental and core to the whole European Union idea, principles, core, may not always consider a number of areas where we could call the European public health goods, or European health goods, or European health system goods. They're areas that, while subsidiarity would argue that should be done at a national level, when you look at the pure economics, and again, Joe, I'm totally bypassing the politics here. I'm taking that purely from an economic basis. I am more aware, or as aware as everybody else is here, about all the politics of subsidiarity and what should be done at what level. But if you look at purely at the economic level, we have a number of public goods that would be better served at the broader level. More arguments, purchasing power. The purchasing power of an European Union is enormous in terms of the ability to get a number of goods, medicaments, technologies, and so on. Externalities is another area. Even the most neoliberal economists would agree that externalities is a reason for actually public involvement, and there are European externalities that we need to, on which we need to work together, because member states alone cannot deal with those. And finally, in these overall sort of themes undermining my more specific points I'm going to make in a minute, is the whole argument about volume, outcomes, and efficiency. It's not rocket science by anyone of us listening today that higher volume, better outcomes in general, not always, and higher volume, better outcomes, lower costs. There are many areas where done at a broader European level would improve outcomes, would improve quality, and would reduce costs. So let's be more specific on that. Take the externalities. Take, obviously, talking about that these days, is the COVID. The COVID is the best example. We do know how well the virus has taken advantage of the lack of coordination in borders, testing practices, and so on. It's a clear example of externality. But I won't talk about COVID, actually. Let me go back. COVID, you see, what COVID has done is exploited weaknesses that they were there. Remember the last financial crisis. Who suffered, Martin, there? The same people. Remember the migration. Who suffered there? The whole issues on the refugees and the lack of coordination. Look at the cost of not having dealt with that appropriately, not in terms of solidarity, which is fundamental, but in terms of the economy, of having not done that well. Commissioner, my dear Commissioner, you will remember the very two important recent presidencies on AMR that we were both together, well, at least the first one on the Dutch presidency. AMR is not rocket science. If cows and human beings cross borders, we need to regulate much more actively. It is not cost effective. Our member states have, thanks to the WHO and the European Union, already in 2000, Commissioner, we have a very good action plan on AMR, One Health, in 2000. We still are not regulating the use of some antibiotics. We still are not regulating a number of interventions. Sorry, you don't like that, Joe?
Yeah, just a quick question. What is AMR? I'm sure everybody knows.
Oh, I apologize. Antimicrobial resistance.
Oh, I definitely
There's been, I apologize. There's been a lot of, actually, Lord O'Neill from the UK sort of developed, had a commission developing and showing the huge impact, potentially far larger than COVID, on the AMR, on the disease, on the mortality, on the suffering, on the economy. AMR is still there. Why member states, while member states have very good national action plans, One Health, Joe, means not only looking, as Martin said earlier, at the healthcare system, but looking at the environment, looking at food, looking at veterinary animals. So many of our member states, thanks, as I said, to WHO and the Commission, have advanced there. But still, we do not have what is a clear externality, a bigger role of the EU or member states working together. That's highly inefficient as well as dangerous. Another area that brings externalities and public good is the role of the ECDC. If we are to be cost effective, we need to learn from each other. My friend here, Martin, in our Joe, we have something called the COVID Health Systems Monitor, that together with the Commission and WHO, the Observatory is a partnership that has it's hosted by WHO, has the Commission and 12 member states. And actually, Joe, we are based in Brussels. it's been looking at that. One of the areas we looked at is mortality or testing. At the moment, the numbers we have are close to rubbish, and I'm sorry to say that.
Close to
We've been really fighting to understand the mortality caused by COVID. Martin can tell us an awful lot about that because of the different criteria. We cannot compare very well even the testing, and yet we are failing to learn from best practices. Why are we not giving more power to the ECDC, more mandate to the WHO to establish clear common indicators? This is not political. This is common sense. The same goes, I would go further. I would make, and that we should be careful, colleagues. The observatory just works on evidence. It's not a political organization. I'm just talking purely on evidence terms, not political terms. But clearly the move of the ECDC towards the CDC, European Centre for Disease Control, moving to the CDC model, having not only risk assessment, better risk assessment with indicators, but also more laboratory capacity, working together with WHO, more capacity on risk management. Having common criteria is not political. We would be able to deal with these and other pandemics much more effectively. I'm getting there. Purchasing capacity, joint procurement model, 446 million purchasing together. Can you imagine the potentials of that? We done quite a lot with the current model, and I admire my colleagues, our colleagues at the Commission, on how much they managed. But as Scott Greer would say, Professor Greer would say, it's more of a bias club. Some people may drop out. There's the prisoner's dilemma as well, lack of trust, which then makes that at the moment, I have the impression, don't quote me on that, and it's a shame it's a shame, we're in a public speaking here, but it could be colleagues.
We're on the record.
It could be colleagues that there's no supply of vaccines. We may be a situation in which countries have twice as much vaccines as they need, and some countries none. Aren't we in a prisoner's dilemma here? Wouldn't it collaboration be more efficient for everybody? Because there's enough vaccines for everybody. So joint procurement, but I think centralized procurement, playing the same game would be so much cost effective, let alone solidarity, which is part of the whole thing, be able to distribute to those who need it more in Europe. But I believe if we work together, we can get both. Wrapping up here, volume and outcome and lowering costs. EMA, European Medicine Agency, Health Technology Assessment. Why duplicating all these efforts? Why do we need to duplicate all these efforts and evaluate the same technology beyond the safety that EMA does very well? Why doing effectiveness analysis and cost-effective analysis? Where are the politics and the subsidiarity on that? Why are we not sharing that evidence? We're not working together. There's no political power in a thing like that. There's no subsidiarity. It's no rocket science. Why EMA or another organization made by member states doesn't need to be an European one? There can be collaboration, cannot do that. Why EMA, for instance, cannot be an organization that manages the clinical, coordinates and approves clinical trials? The European reference networks models, again, our commissioner pushed very effectively. The potential of the European reference networks models now for diseases, rare diseases, working on rare cancers, working on high technology, bringing volume on training. It's enormous guidelines. Again, this is where behind to the United States, because they can work across very easily in a way European reference networks are there, they are working, but they could go much farther. But before we started, Joe, you remember, colleagues, we're talking about research. Research in Europe is very much in the right direction with its pros and cons, but most of the research is in the member states, research in the same areas. Why don't we do like the United States? Bring these funds together. We see small countries focusing on the same areas, very little monies. This is why China, this is why the United States and others can be far more advanced. Isn't there ways to keep our subsidiarity, our political decisions, and at the same time join forces? This should not be a criticism at all of the European Union or the Commission, who's done an extremely good job in that direction. It's about not understanding the real public goods, the real cost effectiveness, the real purchasing, the real externalities. And finally, human resources, and I'll finish here, I've been promising. I've been cheating here. Human resources. We want to forecast and we want to monitor together, and perhaps we want to regulate together. Just not because it's a matter of solidarity. It's not about some member states drawing from the others. We don't want to touch the four freedoms. We want professionals to move around. That's fundamental. But isn't there a way that if we need anesthetists, we try to plan together so we don't steal them or GPs from another country, draw them from another country? Aren't there market mechanisms to ensure that if we do so, there's a compensation for further training? Aren't there ways to have the cake and eat it? Because human resources as it's now has an impact on solidarity, no doubt about that. Absolutely. But also on efficiency. We get a very wrong skill mix in Europe at the moment. Why can we not have both? There is enough supply across the countries. There are many mechanisms by which we can regulate a market. We can get a good training and collaboration together without infringing on the individual powers of the member states. So the point here, again, I repeat, I hope that doesn't come across as political, doesn't come across as criticizing any member state, and indeed not the Commission. I think the potential of an European Health Union working, as Ilona said beautifully, as always, with the WHO side by side with all the enormous capacities there, and taking all these elements at the broader level has huge, not only impact on solidarity, but also on sustainability and cost effectiveness.
All right, Joseph, thank you so much. I appreciate your thoughts. Some very interesting, provocative stuff there. A thumbs up from the boss. Vitinus likes it, some of it. Let's see. I'm going to come to questions in due course, but I have one more panelist that I'd like to hear from before we go to questions, and of course going to the stakeholders. And I can see former Commissioner Violeta Bulc champing at the bit, dying to get in on this. In the meantime, I'm going to warn Anique to unmute herself. She's muted. Yes, now she's unmuted, I think. Yes, so she's ready to go. Associate Professor Anique de Ruiter from the University of Amsterdam is going to give this manifesto the once-over in legal terms. Where do we stand in legal terms? Anique.
Yes, Joe, thank you very much. And I'm very happy to be here and just hear all these very good ideas, and I'm really looking forward to all the inputs that we can have on this manifesto, because in the end I think this should be something that as much people as possible in the EU can think along on and can participate in. So, you know, going back to how health became part of the European project in legal terms, we have seen that, you know, from the very beginning, there was health policy, you know, even when it came to the health of steel workers and black lung disease. But there wasn't any legal competence or legal basis to create health law. And what we've seen in the development of what I call European Union health law and policy is that it developed mostly in other areas. So where Joseph just now talked a lot about, you know, what do we do at European level and what do we do at national level, I would like to take you to this perspective of, you know, these horizontal policy areas when we look at the law, and we see that a lot of what Europe has done in the past has been, for instance, in the area of agriculture, has been in the area of the internal market. So a lot of the law that was made in the past in the field of health did not have health as its main objective, but was really a side issue to other issues. And I think we've come now to a place where we can say maybe it is time that health becomes a principal objective for the European Union. And so thinking about a true legal basis for health in the European treaties isn't about being able to create more health law, because we can create a lot of health law and regulation. And I think many of the things and the proposals that Joseph just mentioned and the proposals that we've mentioned in our manifesto, we could do on the basis of current laws. So it's not really the legal limitations there, but I do think it is important to think about a new legal basis for health law in the objectives that we're trying to reach with our health policy and with our health law, and the actors and the institutions that such a legal basis would empower. Because what we have seen is that health law in the EU has been made by agricultural specialists, has been made by finance ministers in the council, and it hasn't empowered the actors that have the expertise to really think about what can we do at EU level that can improve whatever is going on at member state level. So even when we think about, you know, the application of the principle of subsidiarity, which is about at what level can we best reach these policy objectives, it makes a big difference if there is a lot of health people in the room or if there's a lot of finance and economic people in the room, because they have learned to think in different terms. They try to reach different objectives. And so for that reason, I think it's very important that we, for the European Health Union, create a more robust legal basis in the area of health, where it becomes possible that the health actors within the European Union become more empowered to make health policy. Just one example, think about pharmaceuticals. Why is it not the health experts that are centrally involved in creating our regulation for pharmaceutical, which in the EU, which includes purchasing, you know, which includes issues of stockpiling, etc. For the longest time, this has been an area of internal market law. And so I think that is, my wish for a European Health Union is that we can create a robust legal competence in the treaty for the area of health, so that on issues of subsidiarity, we can have the experts in the room that can really speak to at what level is this policy best made. And that can mean, in practice, that we create less European health law. But at least now we have the people in the room that can make that kind of judgment. And this is, I think, what I would like to contribute for today.
Well, thank you very much. Dank je wel. Aniek, we will be coming back to you, I'm sure. Just remember, we're getting loads of questions now in the Q&A. I'm going to first of all go to our stakeholders, though, who have been standing by and listening to the contributions. They're in the sector and they matter. And I'm going to go first, if I may, to the former Commissioner Violeta Bulc, who was also the Deputy Prime Minister in Slovenia and is up to some very exciting projects these days. I don't know whether she wants to share with us now, Violeta, now that your country is on a wave of success. But if you could give your response to the manifesto, former Commissioner Bulc, that would be great.
Thank you very much, and thank you for this opportunity. You would think, what this former Commissioner for Transport has to do with health, but surprisingly a lot, because just to take into consideration the fact that in Europe we have 400,000 premature deaths due to the pollution, and transport is the second biggest polluter. We are together right there, but I think it's even more. I think that there is no political area where health should not be part of it. And as my colleague Vitinez at the beginning already said, for some reason this has been ignored. I do hope that this momentum brings us back and that we really take a very close look at the negative externalities that we are creating due to the ignorance and lack of taking health as a part of a preventive care, and not wait for disasters to happen, not wait for people to get sick, but really to act and create a healthier society. And that's where I think my contribution comes in. When I sort of retired, I started to run a global sort of movement called eco-civilization. The reason why that happened, and I will share a little bit with you, but for those that are interested in more, there is a full file that it's available to all the audience, and you can take a closer look at it into details. But what did we find out? We realized that there is more and more people who actually we feel that what's happening around us is just not right. And it's really hard to grab the challenge at the neck, as we call it, but it's everywhere where you look. I mean, this decadency is talking to us at every corner. So if we want to find the sustainable answers to all these very pressing matters, I do believe that today's society needs to come together and start imagining the future that we want to live in. And in order to do that, we need sustainable and inclusive cooperation. And that's what eco-civilization is all about, is a proposition to have a common new destination under which we start imagining, we start inventing, we start innovating, and we start implementing something that will feel right, something that will meet our inner cause for the society we would like to live in. So how did we imagine this, and what is really the story? I'm not going to go to the details, but we realized that in our modern society, tools became goals. And no matter what we do, we cannot find an effective response. For example, more and more money we pour into the health system, more and more sick people we have. Something is wrong. I mean, instead of narrowing the gap, we're broadening the gap with the investments that come. So that's why the eco-civilization point of view says, okay, maybe we should refocus back to what is essential to our lives. Beings, including humans, animals, plants, bacteria, viruses, we don't deal with those. I mean, why is virus such a big surprise to us now in COVID? Because we have ignored the fact that we coexisted since the beginning of human race. We coexisted with viruses and bacteria, and we don't put this as at the top of our agenda. Society as the core nest where actually the healthy humans can develop. And of course, land from which we then get our food, and we breathe our air, and we live. And awareness, which is the collective knowledge and collective wisdom we keep ignoring, and so hard, it is so hard to integrate the knowledge throughout various civilizations. And we think that the one that comes next is always much more smarter than the ones that lived before. But the answers are really in integration, not isolation. And that's where we come, we get then to the relationship entity, which brings all this together. And the tools that we put today forward, which is education, which is finance, which is economy, which is sport, or whatever, they are actually elements. They're actually the relationship content among these core entities that create something as we call life and our societies and our civilizations. So how does health fit into all of this? Because of course we could not ignore this topic. We launched a broad global discussion on health in eco-civilization. And I'd just like to briefly share with you the core messages that this amazing group of people, and I'm so glad that Venitas joined us as well, produced, and I'm really just the messenger. So first of all, we're asking for a new focus on quality of life, which means less expensive state. And why do we miss this equation? So better quality of life, less expensive state, which of course we talk about accountability and stewardship over health and well-being as an asset, long-term strategies and action plans, and of course investments that deliver sustainable results. And that's what all this manifesto is all about, and many speakers already touched this. But let's be very bold and very precise in our expressions what we actually want as an outcome. The second, caring means stronger community sense and collaboration. And I was really surprised, I didn't know, but the doctors showed me in statistics that loneliness is by far more damaging to health than smoking. And one cannot be healthy alone. So there has to be in this health system perception room for quality community lives. And you already mentioned that due to the COVID, we became much more aware of this community, importance of communities. And we humans do need hope. We need a reason to live. And usually hope comes from interactions, from collaboration, from close relationships, which we see that in a health system, this is exactly what is deteriorating. So we are calling also for the relationship-based health system, where, of course, which means better society, which means less sick leaves, better cooperation with nature, preventive care, sustainable nature embedded in the structure of itself. So this is what we propose, the 3 focus areas, which I hope could get some ear in among you as well, and we can somehow bring them to the future documents on which are looking for a new solution in Europe. So, couple of facts. There is enough data available today to create a new metrics of progress to see what delivers results and what does not. Unfortunately, we are today focusing on 10% on health issues, but we know that 50% of problems that humans have with our bodies, with our physical and mental health, they come from socioeconomic factors. 20% from climate, 20% genetics, and only 10% really the health issues as we know them today. So let's focus big on big, which Europe always knew how to do. And let's bring these elements on board into a very comprehensive, holistic system. At the same time, there is no sustainable health solution on a country level today. We have positive examples that fuel the optimism, and I would very much welcome the health community to connect very closely with Paris Agreement, with EU Green Deal and Sustainable Horizon and create Sustainable Horizon for health, which means horizontal approach. And of course, money currently invested in the health system is not creating healthier people. As I saw the graphs yesterday when we had our last discussion with within eco-civilization community was shocking. More money, more sick people. Something is wrong here, my dear colleagues, and I cannot really put a finger into it, but something is wrong. So just imagine that we take 1% of GDP, and I guarantee you, we will have more than 2% improvement in health and well-being, which means improvement in negative externalities. And last but not least, the third proposal, which I'd like to share with you, of course, comes from my background. I am a computer engineer by profession. So I do believe that we can use technology better. And the abundance of data that creates many new questions, social challenges, and unprecedented opportunities as well. And even in health, this topic is calling for an in-depth public discussion. First, concept of ownership. And today, let's be open, let's be bold in Europe and say health data will be shared. They need to be anonymous, of course, but they should be shared for the benefit of all. Whatever is created within EU, there should be a big database, big data database that we could then mine in and get the real perspective what's going on in Europe. Of course, with that, we need accountability and stewardship again, and common knowledge and awareness. And we need to start discussing, even in health, like we did it in energy, we did it in transport, decoupling of infrastructure from data, applications and services. I do believe that this is a big topic for health community. The second question is, where is the focus? Ownership versus users' rights. I mean, let's be aware that Europe is walking its own path and engaging on a global scale to get more and more followers away from China, where data are owned by the state, away from the United States, where data are owned by corporations. We want users' rights and user perspective and user ownership to be well presented. So I hope we are taking that on board in health as well. But I'm very much also encouraging an open discussion on ethical disclosure on health 4.0, which is a very common word these days used. But here we need a serious open space discussion and ask ourselves about the benefits of humanity from tech development, digitalization, use of data. I already heard before that poor, again, are paying for the rich. I mean, come on, let's wake up. I mean, we exhausted this kind of relationship, and it's time that we bring some fresh new ideas on board. And here is a big question now. Can we bring doctors back to be doctors and not IT administrators? Can we allow again that the doctor's time is used for the doctor-patient relationship? And of course, avatars could be of an incredible use in a digital format as a storage of history and of the patient. But let's not become a focus. And these are the questions I'm sharing from my community with you, and I'm asking you to at least respond to them or consider them as part of your future solutions. So last but not least, based on the manifesto, which I had the privilege to cooperate on its content as well, I'm also proposing to go beyond just manifesto boldly. And at this point, for some reason, I can no longer move my...
It's the curse of technology, Violetta. It's the curse.
I'm done. So besides,
thank you very much.
I believe that manifesto is very important. Please think about data platform, data for sustainable health, that it has also all levels of holistic health model included. Socioeconomic, behavior-wise, environmental, institutional, social frameworks, and nature itself, genetics and diseases that include also dealing with viruses and bacteria and physical damage. So I'm looking forward to our future cooperation. And again, I would say no politician should be excluded from these talks. Thank you very much.
Thank you, Violetta. Thank you very much for your presentation. I'm conscious that Jozas Olekas is rushing off to a meeting, and I'm conscious of his time. So I'm going to go to him next, if I may. Jozas, are you there? He's there. He's waving. You need to unmute yourself, Jozas. And Dr. Jozas Olekas is a Lithuanian MEP and former Minister for Health in the Lithuanian government. He's also a surgeon, no less. So, Dr. Olekas, away you go.
Thank you, Joe. Dear colleagues, ladies and gentlemen, indeed, I'm very happy to be together with you and discuss this issue. And as a physician, as you said, I hope that you all are well. First, let me welcome this webinar, which is taking place in the context that is still particularly tense for Europe. Our union is facing a serious social, economical, and above all, the health crisis. We cannot help but notice that the latter is clearly challenging our union more and more often late. On the other hand, we have tackled the past economic and social crisis by mobilizing all possible resources. Unfortunately, I cannot say that the same structural changes has been done to improve the health of our citizens, especially in a case such as health crisis or rare disease. I will strain forward in saying, despite the activities of former EU Commissioner, my good friend Vytenis Andriukaitis and others, that health in the mainstream policy of Europe Union has been forgotten for a long time. Actions that can be taken but were put aside have long contributed to deterioration of public health in our union. I must emphasize that the European Union has long been no longer just an area for economical cooperation. For a long time is not longer only about trade, the market, or free movement. The European Union is much more than that, and I know this from the testimonies of citizens that I hear every day. The European Union is the history, culture, social welfare, and trust in neighbor. Most importantly, the public health is the ground for everything that follows. Unfortunately, during this COVID-19 crisis, pandemic, we faced a heartbreaking situation when we could not do enough to help our citizens. It is true that with the help of the best professionals, we have found ways among the existing EU treaties to help and support our member states. However, it was and is not enough. The unbearable stress faced by health system, the lives we have lost due to slow or unorganized action are sending us the last alarm. It is time to open the door to a social responsibility and healthy European Union. Moreover, the time for that has never been better than these days. A survey of citizens conducted by the European Parliament this year showed that as many as 7 out of 10 respondents want the European Union have to stronger power in health policy. In the Parliament, we want to do more than live up these expectations of our citizens. I wholeheartedly welcome the European Commission MFF proposal, which finally took health much more seriously than before. Unfortunately, with the Council removing 75% of this fund for health, our position is simple. We will not agree to a long-term budget proposal that does not meet citizens' expectations and does not consider our core requirements. In the context of the forthcoming conference on the future of Europe, we are sending a clear message for the Council. It is time to share public health competence with the European Union, and to do so not because a short-sighted demonstration of power, but for the better tomorrow for our citizens. Whether we live in the south, north, east or west, healthcare, its accessibility, the quality of service, and the equipment provided have to the same, and the lives of our citizens have to be equal importance. I am pleased that the idea of European Health Union Manifesto and the discussion today come from our group of Socialists and Democrats. We continue to fight for a social Europe that is equally healthy for all. I am particularly pleased with the webinar taking place today, and I will be happy to sign this manifesto and present discussion results to our political group. Thank you very much for your attention.
Achu, thank you very much. Now I'm going to ask Markus Schneider to unmute himself because I'm coming to him very shortly. Just for those of you who have posted questions on the Q&A, I have not forgotten you. Don't worry. We have a lot of very serious experts here that we wanted to hear from, and then we'll put your questions to them. So the question from Mihail, we have not forgotten you. From Gillian Deutsch from Politico, we have not forgotten you. From Michelle from the EPF, we have not forgotten your questions. And we've 2 or 3 questions from a guy called Anonymous. So we will come to Anne in due course with her question. In the meantime, I'm going to ask Dr. Markus Schneider from the Basis group in Augsburg to share with us his thoughts as a major stakeholder and what he thinks of this manifesto. Markus.
Yeah, Joe, thank you very much. I would like to say first that I think Europe is a success story, and we should not forget that. But the point is that it's not for all a win-win situation. And I would like to share with you some slides and some data more from a macro perspective point of view. Joseph discussed about cost effectiveness more from the micro perspective, and for pharmaceuticals, medical products, and the economies of scale and scope in that area, I agree with that. But the major issue is the service sector. And let's show you some slides. Now, if we follow the paradigm that health and social care, it's not only a cost factor, but a job motor, a growth engine, then we see already what happened in the last 20 years. In the last 20 years, of the 23 million new jobs which were created in Europe, in the Europe Union of the 27, 6.1 million new jobs were created in the health and social sector. So that's 26%, but very unevenly distributed among countries. So we have Czech Republic, Germany, with more than 30% of jobs, of the total jobs created in that sector. And on the bottom line, we have Slovak Republic, Bulgaria, Romania, Poland with very few jobs. Why is that the case? Not all we understand, but certainly it's an issue of the result of regulation of markets, of historic developments and attitudes, what we spend in the health sector, in the health and social sector. Now, health care is certainly the largest single sector in all EU countries, and it's very important for the income of the people living there. Now, what we observe that in some countries, or particularly in the center, in the gravitation of the European Union, demand for health jobs in high-income EU member states works like a vacuum cleaner in the health labor market of member states with lower income. Now, let's look on health and social care as income growth motor. Now, we have said 26% of additional employment was created in the health sector, but only 6% of additional value added was created in the health sector. On average, the relative income per employed working in the health and social care is 33% of that average income per employed of the total economy, which is 57,000 euro. And the additional value created by health and social sector in the last 20 years, it's mainly in the Nordic country and in the center. And what you see, where are the losers of this development? Highest contribution.
Marcus, I'm just going to interrupt you very briefly, Marcus. We can't see your slides, but if you could send your slides so that we can share them with all the participants and those people who are in the audience later, that would be great, but we can't see them at the moment.
Okay, thank you, Joe. I sent it already around to the organizer. I think you should have it, but I can do it again.
Okay, if you could do that. So
yeah,
can't see it.
I will do.
I'm talking about the people who are dialed in who may not have it already.
Yeah. What I think it's important to see this very uneven development of income growth and employment growth and the consequences behind that. And what we can also see or conclude from that unequal capacities and productivities provide opportunities for improvements of income growth and investment in the future. Now, there are a lot of studies around and strategies all come to the conclusion that all EU member states face additional demand for health jobs. But uncoordinated health policy and uncoordinated education and training of health professions will aggravate shortages in EU member states with lower income. If you look to the slides on the right side, from these 6.1 million new jobs created, half were created in Germany, in France. And then a few other countries, and the rest created very little jobs because already of shortages and outflow of health professionals. So the manifesto then says work together to reduce the brain drain from east and south to the west and north of Europe is complete right. Uncoordinated health policy and uncoordinated education and training of health professions will further hamper the convergence of income among European member states. Now, the market measurement of value added, what is the GDP, does not tell us the whole story, certainly. And COVID-19 shows us that we have to consider also the value change, not only the value change by industries and in the general economy, but also the value change in the informal care, in household protection, which are heavily touched by COVID-19. In contrast to the first wave of SARS-CoV-2 infections, Central and East European countries face increasingly hotspots of new infections. And you can see it on the slides. These are data from yesterday from ECDC. I think ECDC provides good data in the development. One can question certainly the level of this information, but I have to say I really appreciate how accessible are the data, and during the whole time what they put on their web, it gives you very valuable information. But what is obviously the case, that the resources to fight against COVID-19 are very differently distributed across Europe. Actions to support public and private health activities across Europe have a high return on investment. And these are absolutely necessary to keep also the balance within the European Union. So I agree with the manifesto, commit to creation of European Health Union will support the further income development, GDP, and peace in Europe. So thank you for your attention.
Vielen Dank, Markus. Vielen Dank. I am going to open it up now to get through some of the questions that you have sent to us. And I'm going to go first to Gillian Deutsch from Politico, who gave her question a little bit earlier on. I don't know whether, Gillian, you're still there. Hopefully you are. First, countries cut the Commission's bolstered proposal for a health budget. Now, how realistic is it that countries are going to give up some power even in emergencies? And secondly, we hear that the ECDC, the European Centre for Disease Control, needs to have a bolstered mandate or a beefed up mandate to better help the EU. What power should they actually get? And that's from Gillian from Politico. I'm going to put that, if I may, to Ilona. Ilona, did you hear that question? First of all, unmute yourself. Maybe you are focusing on something else.
Can you just repeat it quickly?
Okay, I'll give you this one. How about this one? How realistic is it that countries are going to give up some power even in emergencies?
Well, it's not a question of being, how realistic or not. It's a question of negotiation. And we have often seen in crisis situations that countries in the end are more willing to work together and to actually reconsider. So that's why I think, the next 12 months are going to be absolutely critical. We will have several recommendations on the one hand from the independent panel that WHO has put in place. On the other hand, from the committee that is looking at the international health regulations. We had suggested changes to the international health regulations after Ebola. I was part of the review committee then. At that point, countries were not ready to move. I think the experiences with COVID-19 have truly been a wake-up call. And if you look at all the preparatory papers that have been written, even by the United States, but in particular in the last weeks, the so-called German-French non-paper on reform, it very much highlights very similar issues on how it is necessary to increase the independence of WHO, how it is necessary to either incentivize or sanction countries who do not deliver data and information to the extent they should. So the issues are very clear right now, also from the Global Preparedness Monitoring Board. And if I can go back to a point that we have seen in global health repeatedly, that changes that we never thought would be possible actually became possible in or through a crisis. We built new institutions like the Global Fund for AIDS, Tuberculosis and Malaria. After SARS, we actually built the international health regulations and got them agreed. After the Ebola crisis, a totally new approach of WHO was created in health emergencies, a big department and new ways of action. We see right now that a strong science department is being created in WHO. So that's why, you know, this sentence, never waste a crisis, is absolutely critical. And we are at a point where, as I always say, the big powers are sort of not ready to act, but the middle and the small powers are. And, you know, global cooperation is most important for small and middle-sized countries and powers. And therefore, that's why the actions of the European Union are so important, because they are a grouping of small and medium-sized countries, but together they can be a global force. And I think we really have to push that the European Union fulfills its global responsibilities. Then change can be more realistic.
Thank you very much. Martin, I'm going to give you the second half of that question. If you could unmute yourself, Martin, get yourself ready.
Sure.
The second part of the question from Gillian Deutsch is the ECDC, the European disease control body, needs to be boosted. What power should they actually get, do you think? Martin McKee.
Well, it's less power, but more responsibility. One of the things that we have seen during the current pandemic is the struggle to get comparable data on what's been happening across Europe. So we haven't been able to get even all-cause mortality, weekly all-cause mortality for all of the member states. We've had major problems with the definitions of deaths and cases. Now, one could argue that this is the responsibility of Eurostat, but of course Eurostat only coordinates the work of national statistics bodies. And I think this has highlighted that we need to bring this together in some way. Clearly, the distinction between infectious and non-infectious diseases is really an artificial one, because among those who have died during the COVID pandemic are not just those who have died as a result of the infection, but also there are those people who have died as a result of the countermeasures, for example, difficulty in accessing care. Similarly, the high burden in some countries of people with complex non-communicable diseases has been a major contributor. They are the people who have died in greatest numbers. So from that point of view, I think it's the range of conditions that ECDC can have oversight over. It doesn't have very many powers, if any, in itself. It isn't an implementing agency, but I think having that broader scope would be very important, simply to bring together a comprehensive picture of health in Europe.
Okay, Martin, thank you very much. I'm going to go to Josep Figueras. If Josep is still listening and he could unmute his microphone. In fact, let's unmute all the microphones now, because we're going to be whizzing through these questions. Josep, I know you have some strong thoughts on the ECDC. What powers do you think they need? And I'm going to throw you a second one. It's my own question, please, Josep. The WHO, it's been referenced a lot here just now by Ilona. Its biggest contributor, the United States, says it's pulling out. And if President Trump is re-elected, that will become a reality. How will that impact the WHO? Two questions for you there, Josep, no pressure.
Well, the latter is quite out of pressure. On the former, I think, as always, Martin has addressed that beautifully well. We are basically flying blind in many instances when we're not able to compare what's been called this beautiful natural experiment in Europe, where we can see so many approaches to deal with the pandemic, but not only with the pandemic, with many other diseases. And the fact that this data is not reliable, is not comparable, is not speedy, is not integrated in the policy decision making quickly enough, it's a real problem. I think, and it's not up to me to say that, in terms of mandate, I think the ECDC could take more of a similar mandate. I don't know what you think, Martin, of the CDC, and perhaps go more into areas of risk management as well as risk assessment. I think on testing policies, for instance, in laboratory capacity, always, as you talk at WHO, very much well coordinated with WHO. It's not rocket science to develop these measures. It's not rocket science what needs to be done in many instances, but it's really the work of getting together different member states and agreeing on these common measures, in these common interventions, and then giving the mandate to the ECDC and the WHO to be able to implement them, regulate them, monitor them, and benchmark them. As to the role of the WHO, that's a question I'd like to pass back to my dear friend Ilona, as to what is going to be the impact. Perhaps there'll be a change in government. Obviously, I'm not taking any position, and that will not be an issue at all. I do believe, though, that in some ways there's a silver lining on every single crisis, has been said already. The Churchillian point about not wasting a crisis, and I think that crisis has given us the opportunity to realize that WHO is doing an awful lot for the budget it has. The Economist last week, I think it was, or 2 weeks ago, had an excellent article showing that the budget of WHO at the moment is not larger than a small region, a small city in many Europe on health in many countries. Number one, it pointed out, number two, that a good percentage of that budget, the largest percentage, is tied to priorities of member states. The core budget itself is the minority, and that's the one that WHO can follow, the priorities of member states. The rest is individual priorities of member states. So I think it's highlighted that WHO is doing an awfully good work compared with its capacity, compared with its mandate. That is range is very wide. Look at from its direct work in the countries in Africa with Ebola and elsewhere. So in some ways, perhaps this withdrawal of the United States has been a great opportunity to examine the organization, to strengthen the organization. I believe, Ilona, that the review underway currently actually will be very positive for the organization strengthening, and we'll see more support of other member states, will be more support of the European Union and others, more support of Gates, without, point taken made by Ilona earlier, hijacking the agenda of WHO altogether.
Okay, Ilona, you can answer that in a second. I just want to forewarn Aniek de Ruiter that I'll be coming to her. She's muted at the moment, so if she could unmute and get ready for her question, that would be great. Ilona, do you want to take on that question from your colleague, Josep?
Yep, just to say that this German-French non-paper that I mentioned actually calls for a change of financing in WHO. It calls for a significant increase in what Joseph called the core budget, what we call, assessed contributions. That is the contributions countries are responsible for paying. And I think there's a strong move to see a significant change there. In relation to our own discussions here, this is important also because Germany has the presidency of the European Union right now. So as a presidency, as chair of the Council, it's absolutely critical that they move that agenda forward, and they have every intention of doing so. I might add, we've seen it through COVID-19 that European countries, and I'm just going to use that big umbrella right now, have been incredibly generous for the WHO in helping them address COVID, in contributing to many of the initiatives. We would always want more money, obviously, but it's a signal also that money is there. Germany alone went there recently with $500 million. And I think we must also see that if we start to think Europe's role in global health, we have to add up because if you add up the member states of the European Union and their contribution to WHO, it's actually much higher than that of the United States. So we also have to look at that budget differently and take a different political approach to it. Definitely, we're hearing in Geneva from many member states that they have every intention of strengthening WHO rather than following the line set by President Trump.
Thank you, Ilona. And of course, Vice President Joe Biden has said that the very first thing he will do if he wins the election is to reinstate US membership to the WHO.
Yes,
okay.
but can I add here, it's, you know, we actually want to move away from that domination of budget by one country.
I get that. I just wanted to add that line. It's important that we add that line. So things may go back to the way they were. I'm going to put this next question to Aniek de Ruiter. It's from Michelle from the EPF, the European Patients Forum, I hope. Michelle, you had a signal if I'm representing the wrong group. Thanks for this very interesting discussion. How would you envisage the role for civil society in the European Health Union, Aniek? They're talking about patient organizations, etc., in shaping and co-designing a robust and inclusive EU health union from the very beginning. Aniek.
Well, I mean, we were just talking about the big budget that was created in the EU for Health program that then later on was diminished a little bit. I do think there's a tendency in the EU to distribute funding through all kinds of executive agencies, etc. And so I think one of the big problems is that for the EU to have a real political role in the field of health, it needs to involve the parliament. It needs to involve a left-right discussion to some extent. And in the past, the role of the EU has been mostly in sort of safety and regulation, where there wasn't a lot of redistribution. But now we see, for instance, we're getting a vaccine that is going to be distributed based on medical need. So there are some elements where distribution is starting to happen, and issues of solidarity are coming very much to the fore. And so we need to ensure that the European Parliament is empowered to speak about these issues. And for the role of civil society, I would say it should matter that you write to your parliamentary member in the European Parliament. And it should matter if you ask a member of the European Parliament that is more from a more left-leaning party or from a more right-leaning party in the EPSCO committee to try and influence them on their positions on health. And right now, I don't think we really have that type of discussion in the European Union. And I think it has a lot to do with funding. It has a lot to do with the ability to redistribute and to make a difference in that regard. And I don't think that the EU should really take over completely from the member states as well. So I do think we need subsidiarity there. There's huge differences in the healthcare systems across the EU. It should only do this type of we should only have this type of discussion where the EU can have an added benefit, where it matters, for instance, in alleviating some of the huge health differences that we have across the EU. And so I also would sort of warn against having a majorly grand idea about EU redistribution or anything like that. But I do think it should matter much more, and we should think about the funding that we do have to redistribute at EU level, and the political discussions that we should allow to take place in that regard. So less distribution from the executive, more input of the European Parliament in the type of programs, health programs that we do have, etc. And I think there is an in for civil society. I think we should move a little bit away from civil society always having I mean, I'm all for participation, but I think we should really also bolster the political discussion within the parliament with elected officials. And so I think that should be the direction. The other thing I think that I would really advise civil society to do is to take this manifesto and the ideas of this manifesto and start writing letters to your national parliamentary members. because they also have a say about their government's take in the council meeting in Italy in the next year. So I think this is something that's very important, and it's often forgotten by civil society. Start writing to the national parliamentary members to start asking your governments, your national governments, questions about what stand they're going to be taking in the EU for health.
Okay. Aniek, thank you very much. I hope Dr. Andriukaitis is standing by. Can you hear us, Vytenis? You can. If you can unmute yourself, I'm going to put you a question. We got it from anonymous contributor, so I don't know who it is, male or female. And the question is, Vytenis, how realistic is it to expect that EU funding for health will be similar to agriculture? Now, agriculture, as you know, is the single largest receiver of money, and I'm sure Violetta Bulc will have some thoughts on this as well. She's smiling already. It used to be 70% of the entire EU budget, and I think it's around 40% now. I could be corrected. So, Dr. Andriukaitis, what do you think?
Sorry, I would like to tell you, first of all, please calculate how many money we are putting to keep our agriculture high and competitive. I heard some parallel. Now we are delivering 50 euro cents to European students through Erasmus program, and 2 euros to 1 cow in our, in our agricultural policy. Of course, it's not realistic at the moment, because do you know why they decided, heads of states and governments decided to reduce program of EU for health program on 75%? Because they decided to give more money to direct payment to farmers. Can you imagine? They decided to reduce the health program because of that. It's unbelievable. It's unbelievable, because farmers are also sick. They are also they need to have healthy conditions. But unbelievable. But it was decision. It was done. It's ridiculous. But nobody knows, because it's all closed doors. And we also are thinking, how can we improve transparency of our Council of Europe? We need to have, clear picture. If you look at European Parliament, we know how our members of European Parliament are voting for whom. But at Council level, it's just a closed box. But it's not transparent. And of course, it will be good now to move forward, speaking about possibilities really clearly. That we need to understand that people's health is out of attention at Council level. I was Commissioner for Health, and I had in my hands vaccine bank to vaccinate cows, but I didn't have bank to vaccinate to help Romania to vaccinate children because of measles outbreak. It's ridiculous. It's ridiculous, but it is reality. When we are speaking about real situations, we need to understand now that health should be high on the public attention, and that our debates and NGOs, civil society, can help us really to change situation. Because otherwise, if we will continue in this way, and always thinking realistic or not, please look how many regions are abandoned without nurses and primary healthcare practitioners. And what people are thinking about EU? They're thinking that, that such EU is not ours. It's not close to our hearts. And of course, also, then you ask why they are voting in favor of some radicals and, who are against European Union. Now we are in crossroads, not only because of COVID crisis, but because of crisis of confidence in the EU project. But if we are not ready to keep our eyes on quality of life standards, on possibilities to improve people's health, it will be this big distance between institutions and understanding and between member states. I think for me it's crystal clear. Now we need to act and to join our forces to really to change situation on the ground.
Martinez, I can hear your passion about this subject. I think it's coming through very clearly. I'm going to go to Violetta Bulc to see whether she wants to add anything to that issue. Agriculture still commands the lion's share of budget from the EU. Should it remain that way? Should we invert it so there's far more going to health and far less going to agriculture?
Well, this is a very direct question. I will try to respond as directly as possible. And I'm an engineer, so I will say depends on. And I think we have to have a system view on everything. So I cannot just shoot, okay, take here and put it there. I mean, what is the purpose? What is the outcome that the EU wants to have? Do we want to have a healthy society? Do we want to have healthy, engaging people who actually spend time delivering value to themselves, families, and societies, or to be sick and pay bills to hospitals and pharmaceutical industry? I don't know. I mean, we need to clarify this kind of points of view. We need to clarify what kind of society we want to be in 30, 40, 50 years' time, and then discuss who should get the money for what. We need healthy food. So we need a healthy environment, healthy soil. So this is all part of the holistic approach. And what I would invite my colleagues from health is that in order to put health as a horizontal political topic and put it on an overall political agenda, also health professionals need to get out of their bubble and they need to start talking horizontally to all others and really engage with the outcomes more than with the challenges. So I think the whole society, this is not going to be overcome overnight, but the whole society is now put at the big crossroad. Can we imagine a happier, healthier society that has well-being at the core of its overall agenda, social, political, economical? I think we can. I think we're challenged enough. And then we can talk about budget. But Vitinis is right. There is a discrepancy that is screaming and is asking us to address it better.
Okay. Markus Schneider in Augsburg. Quick question for you. Which areas of health are most in need of pan-European solutions? That is a question from Anonymous, so I don't know who asked it.
No, there are many areas. I think one should not concentrate on one issue. We can start, for example, the financing, as we just discussed. I completely agree to have a system view on that, and that means that we first start maybe with the question where we should not harm the situation in the countries by EU policies. So starting from the value chain, I think research, education are certainly on priority to do something. But then if you go into certain areas, you could think about children. You could think about our future and what is most important for our future. So the point is to start and then to develop the system. And concerning data, certainly more has to be done on digital health. Digital health is a very weak point, maybe also in the CDC, because you need really money. You put money in hand and you need European platforms, what we not have. We now go to Google to map what is going on. And if you look on the app, which was developed by in Germany, is now in use for COVID-19, we are really in the beginning of this development. Okay. So I could continue to go to the hospitals, to intensive care units, and so on. There's a lot to do, and one can make with 100 points certainly, and then give it to the Parliament and to discuss that.
Okay, we're in the final lap of our Q&A, and I'm going to put one or two more questions. and then I'm going to ask Ilona to wrap up the session, if I may, in a few minutes. Question for Martin. I don't know whether he fancies this one. How could business organizations contribute to a European health union? Martin McKee.
Well, they already do contribute in many ways, both positively and negatively. So I think what we need is absolute transparency in those relationships. That's the first thing to say. You know, of course, business is part of the solution, but we've seen far too often that there are the manufacturers of health damaging products, often exerting their influence rather invisibly, shaping the narrative and moving at what we call the Overton window, the range of things that are acceptable or not acceptable. But we need to have a dialogue that is open, transparent, and visible to the public, and then we can move forward.
Okay, Martin. Joseph, if you could unmute yours for a question also from Anonymous. A lot of very shy people out there who don't want to give their name, rank or serial number. Joseph Figueras, will the debate on the EU health issue continue once the pandemic is gone? It's a very good question. When the spotlight has disappeared and people aren't as interested in the story, maybe in a few years' time, will this issue disappear?
No, I don't think so. We've been doing some work, as I said, in the observatory around resilience. And the concept of resilience and health systems is about dealing and addressing and preparing for new shocks. COVID has been a shock, maybe other pandemics, but there are other shocks. There are shocks around sustainability, about the aging and so on. I think it will not disappear. I think this time, because of the nature of the crisis, I think we are learning the lesson. I think we are going to strengthen our systems, our collaboration for the future. I'm very optimistic there. I think member states, I think our policymakers do realize that this has just been a big shock, but there are many others in the store. And if we don't work together, we are going to sink. On that, Joe, as I have the word now, let me highlight one aspect that perhaps we haven't highlighted enough. Some of our colleagues have, however, which is we talked a lot talking about the phases of EU policy, as my colleagues Wismar and Greer have been writing about. We talked about the public health and the health phase of EU policy, but we haven't talked as much about the internal market. Of course, Violet is talking about the transport, talking about the food, talking about agriculture. But really, the other area to strengthen as part of the European Health Union, Ilona is an area that she's been pushing very much, is precisely the role of health, a health component on so many internal market decisions. The potential of that European Health Union, the Commission, is per se a health in all policies organization. If we could really use that power, that capacity to really get health in these so important areas, environment, equality, and so on, labor, this is perhaps where the largest potential is, where subsidiarity has not even discussed, and yet where the biggest potential is. It's been mentioned, but it should be mentioned a bit more. The third area, if I may, is the area of the fiscal governance. There's been a huge potential with the European semester, Joe. The European semester is an area that was put in place for the sustainability of fiscal sustainability of the member states. But in the European semester, we see in recent years to introduce areas like health and social care as part of the recommendations of the Commission to member states. Now with the Resilience and Recovery Fund, huge fund, there's a huge potential there in terms of fiscal governance, in terms of fiscal impact on health. We should not forget that. If we're talking European Health Union, we need to work on that fund because it can make a huge difference. And it could be very negative as well. We learned from prior experiences about the structural funds and other initiatives that went not necessarily in the right investments. So let's think as well, those other instruments that perhaps are not as much in the minds of our citizens, our policymakers, but are fundamental for the health of our Europeans.
Thank you. Gracias, Josep. I'm going to come to Ilona shortly, but a final question for Aniek. If you could unmute yourself, Aniek de Ruiter. You're still, there we go. And it is a brief one, a brief answer if possible, Aniek. Do you think in the course of this commission, which has whatever 4.5 years left to run, there will be a European Health Union?
Well, we're only now in the process of defining what exactly is a European Health Union. Just from my perspective, do I expect that there will be a stronger legislative competence with health as its primary objective? Then I think, yes, there could be a change there, but it depends very much on if we use this window of opportunity, which it is in a way, unfortunately, to push this through, because the current article in the treaty is quite messy. There's some terms in there that really, incentive measures, we still kind of don't know what it means. So there's an opportunity for a cleanup there, and to make it, as somebody mentioned, just a shared competence. I think that there is an opportunity for that to happen. But exactly what a European Health Union means, and if that will happen within this term of this Commission,
Ambitious.
I'm not going to make a final statement about that.
All right. Well, thank you, Val. So, Ilona, I'm going to ask you to wrap up and give your final thought, please, on behalf of the EIHSD.
So, how can I summarize such a rich discussion? And I think, aside from the manifesto, the compilation of all the ideas and points that have come out in this discussion through those excellent questions that were put to us, I think will help us move really a step further. I'll just summarize, if I can call them, some high-level issues that seem to me to be critical and where we will need to have answers to. One is really, as was highlighted, what's the goal? And, we say a European Health Union. What does it want to achieve? And we've heard a lot about that its goal is also not only in relation to the citizens as such, as important as it is, but that it is a wider systemic challenge. And both Martin have highlighted that, which means that other policy arenas like the Green Deal, etc., are absolutely critical. So while on the one hand, we need to have that health focus, on the other hand, we mustn't get too narrow. And I think that that message was really very, very important. I think another thing was that in that context of the goals is, what is it we really want to do and create together? Even before we move to the legal dimension that Anneke has highlighted. And again, both from me, but also from others, was the question, what are the common goods? What are the European public goods, or however we want to call it, that we want to maintain or that we want to create? What is the solidarity component of that? And I think, the health workforce is one excellent example of a total lack of solidarity in that context. And we are hoping that, vaccines will not be similar. So I think that while at the first instance, the thing is, oh yes, the goal's clear, we might want to be even clearer about that. And of course, we have the SDGs and this and that and the other. But I do think also, again, something that was highlighted, that of course, one of the overall goals within that system is the equity within the union, the health equity and the social determinants. And of course, the whole question about social Europe, just like the Green Deal, is critical for any EU for health and European Health Union. I think the second big issue was also that all parts of the European Union, all constituent parts, need to be involved in this process. And so, of course, we think of the Commission, and it has taken a number of actions it definitely wouldn't have taken a year ago. But There's the role of the Council, and that leads also to what Anniki mentioned. To what extent are there discussions with national parliamentarians, with European parliamentarians to take this forward? We've heard from one of the parliamentarians, and I really think that, you know, this political process of consensus building through the parliamentarians who are representing the Europeans is absolutely critical. That is, of course, related to exactly what was also in the last question, how could it become a legal part of the EU treaty? And there's a lot of issues related to that, but they can only be resolved politically. And therefore, you know, the parliamentarians at home and in the EU are absolutely critical. And that, for me, also is the linkage to citizens, you know. And if we think of elections for European Parliament, etc., this issue of, you know, can health be a glue for a stronger union in general is very important. Two other points, because we'll be running out of time, yes, is one issue that Josep raised. Let's do a better analysis of all the instruments we actually already have, and if we're using them well enough. He said we have more instruments than we think we have. I think that's really critical. I think the other side of that is to say, yes, so many policies are made that have an impact on health, the health in all policies argument. How do we make sure that this European Health Union is always part of that debate, and that goes beyond simple health impact assessments or something like that. It's again really a political debate. And the last point I'd like to raise then is, I do think we all understood that, there's the trans-border issue, of course, within Europe, but there is the global responsibility and the global role of the European Union in relation to global health, the World Health Organization, and the health of the world, and common goods for health globally. And that to some extent, this whole process should also include a strong leadership position in the context of being, as the EU has maintained it wants to be, a responsible geopolitical actor.
Thank you very much. Herzlichen Dank to Professor Ilona Kickbusch in Geneva. I'd like to thank, even though he's no longer here, Josas Olekas from the Lithuanian MEP, former Minister for Health. Thank you, herzlichen Dank, also to Markus Schneider in Augsburg. And to, I don't know how to say thank you in Slovenian, unfortunately, Violetta Bulk. Thank you very much, and good luck with the project that you're going. And I herzlichen bedankt to Associate Professor Aniek de Ruiter, who is in Bergen, but is associated with the University of Amsterdam. Gracias to Josep Figueras. Where are you, by the way, Josep? Whereabouts are you physically? You're on your muted.
Brussels.
You're in Brussels. Oh, I didn't know they spoke Spanish there. There you go. And finally, so Martin McKee, who is sitting in Crouch End in London from the School of Hygiene and Tropical Medicine. Thank you very much, Martin, originally from Belfast, of course. And my last thank you is, of course, to former Commissioner Dr. Vytenis Andriukaitis, who put this all together and made it all happen. This webcast can be viewed again. So if you, it's going to be uploaded. I know my colleague Audrius is going to mention it again, but you can catch it again on bit.ly/Health Union Webinar. That's bit.ly/Health Union Webinar.
Oh, I propose something. Could they tag us that we can see where it's going to be published and we can then republish? Otherwise, it's really hard to find in the.
Yes, oh, absolutely. I think my colleague Audrius is going to do all of that.
Okay, super.
He's
May I ask you also, may I invite my team here to say goodbye to you because I need to be transparent. I am very happy
have
to
thank the
show
people that make it happen. I
my
agree
team.
totally.
Colleagues,
so there they are.
let's
Okay.
join us. Let's
There's
join us.
There's some other guy, I didn't get his
Thank you
name.
for everything. They were
Thank
excellent.
Thank to Tamara for also making it happen in the background. So
Colleagues,
as they say,
let's join us. Let's go. Let's join us. Let's go. Okay, you see our team. Please,
wow,
please go here. Please
oh my God,
come here. Please come
it's like
here.
an ice hockey
Please
team.
come here. Yeah, it's gender balanced team.
Gender
you
neutral
know,
or gender balanced?
It's clearly yes, yes.
Good.
Okay.
Hello, everybody, and thank you. Or Zudie, as they say in Lithuania. Zudie.
Zudie, yes.
So, and from me, Joe Lynham, you will be able to watch this again. Goramila Mahagut, as we say in Ireland.